Okay, we certainly want to thank Associate A.G. West for his comments and remarks. And I know that some of you might be thinking we traded remarks because there's a lot of common stuff. You'll hear that all day long. All right, so we're going to pick up where we were. Okay, so here we come to the crux of the problem. Here we come to the crux of the problem. Historically, the vast majority of justice-involved individuals have been uninsured and have not had access to health care services in the community. A few people have health insurance when they come to jail, and we know now that at the point of release, approximately 90% of these folks do not have insurance. But despite having low income, most justice-involved individuals were not eligible for Medicaid because they were childless adults, a group that has historically been precluded from Medicaid eligibility. As you can see, as we go forward, we've got a chart that will talk a little bit about the eligibility. By giving states the option to expand Medicaid eligibility to adults with incomes up to 138% of federal poverty level, and by the way, there are 25 states plus the District of Columbia that have implemented that to date. And by establishing health insurance marketplaces, the ACA has created access to health care for many individuals that were previously uninsured. And this is the first time that that will have occurred. But simply expanding eligibility is not enough. In Massachusetts, where the Romney Care Initiative established universal health coverage, one study showed that 22% of the individuals admitted were uninsured. And this population consisted of disproportionate numbers of low-income, minority individuals, similarly striking to that population that we see in jail. The lesson here is that expanding eligibility to new groups does not necessarily result in automatic enrollment. So, it is especially difficult for this population because they seek to remain hidden. As Steve mentioned, the reason we're here today is because of the new opportunities that the ACA has created, and these opportunities begin with enrollment. Through Medicaid expansion and the establishment of affordable marketplace coverage, the ACA has created an unprecedented opportunity to enroll people in coverage and provide access to services, and the jail could very well serve as a vector for this effort. Although services delivered to individuals while in jail cannot be reimbursed by Medicaid, individuals may still be eligible for Medicaid. And by enrolling these individuals at the front door or the back end, we could move one step closer to establishing a seamless system of care from the jail to the community and from the community back through the jail. Besides covering more people, the ACA requires Medicaid expansion, as A.G. West mentioned, and marketplace plans to cover the 10 essential health benefits, including coverage for mental health and substance use treatment, which has to be at parity with other physical health services. The end result here is that we have more people with coverage and they have access to more services directly related to their needs, including people who have come into contact with the criminal justice system. And this is certainly a population that has remained hidden from the public eye for far too long. The ACA means that we're living in a time of new opportunities for courts, prosecutors, public defenders, sheriff's departments, probation departments, policymakers, and other stakeholders to improve public safety, improve public health, and to maximize the stewardship of our public resources. So now, let's see some of the folks who will be helping us discover the ways that we can leverage these new opportunities in this first panel. Joining us will be Dr. Summers, Marcia, and Elena.
And while folks are assembling, can I ask those of you, thank you, Michael.
Let's go do the intro for them.
I know, before you do it. Can I ask those of you seated, standing in the back to try to find seats in the front? We still got a lot more folks coming in.
Okay, do a little bio on your presenters here. Dr. Summers is President and Chief Executive Officer and founder of Centers for Healthcare Strategies, and he's been responsible for the organization's growth into a nationally recognized center on improving care for beneficiaries of this country's publicly financed health care programs, particularly those with chronic illnesses and disabilities. Dr. Summers is a visiting professor, lecturer at Princeton University's Woodrow Wilson School of Public and International Affairs. We welcome him with us today. Dr. Regenstein is a professor of health policy at George Washington University. She also directs the Milken Institute School of Public Health's Doctor of Public Health program, and she's conducted dozens of studies that focus on the availability, quality, and cost of care for underserved individuals. She is also the Director of Research and Evaluation for the National Center for Medical Legal Partnership and is Principal Investigator for HRSA-funded evaluation for the Teacher Health Center program created by the Affordable Care Act. Ms. Nicolella joined the Rhode Island Executive Office of Health and Human Services in September of '09 as the Medical Director. She worked for the federal government for 15 years, first with the Food and Nutrition Services in the U.S. Department of Agriculture, and then with the Centers for Medicare and Medicaid Services. Recently, she was asked to lead a new Office of Policy and Innovation where she will focus on using data and analytics to drive program evaluation and improvement through the Executive Office of Health and Human Services. So without further ado, we will now hear from our panelists. Marcia.
Okay.